Hi, my name is Jeremy Moore, and I'm going to be discussing the past and present of twin AV nodes. I have no disclosures. So the overview, I will talk about the anatomical substrates of twin AV nodes and associated congenital heart disease lesions. We'll talk about the epidemiology of SVT. We'll talk about the EP substrates and principles, and finally the outcomes of catheter ablation. Beginning with the anatomy, I want to describe three specific features of twin AV nodes. First of all, are there two AV nodes in a given patient? Number two, do the AV nodes themselves connect to an AV conducting bundle, which is important for reentrant SVT? And finally, do the AV bundles connect to each other in the form of a continuous conduction sling? All of these things are really important from an anatomical perspective and have been described in the literature. As most of us know, the first case of twin AV nodes with a connecting sling was described in 1913 by the German Mockenberg, who described essentially a CCTGA patient who had cytosolitis, AV discordance, and double outlet right ventricle with a continuous conduction sling. It wasn't until 1973 that the next pathologic description of connection of twin AV nodes and a connecting sling was described. And then in the following year, 1974, a series of CCTGA patients was described, all of whom were found to have duplicated or twin AV nodes. However, only one of them had connection with the AV conducting bundles and a conduction sling, and that patient was described as having good septal alignment, which is important, as we'll see. So there's a lot of excitement about CCTGA at that point and the AV nodal anatomy. And if we look at the different variants of CCTGA, we find different anatomical correlations. For patients who have cytosolitis, we do see duplicate or twin AV nodes. However, the posterior node in the normal location is underdeveloped, hypoplastic, and doesn't connect to an AV conducting bundle. On the other hand, the anterior node is typically very well developed and connects to an AV conducting bundle for sinus rhythm to conduct. Alternatively, with situs inversus, the opposite essentially is true. We see that the posterior AV node is well developed, and this connects to the AV conducting bundle, whereas the anterior node is hypoplastic and does not connect. And in the two subtypes, pulmonary atresia and double outlet right ventricle, one typically sees very good alignment between the atrial and ventricular septae. And in this situation, in these two subtypes, oftentimes we'll see twin AV nodes that both have connections to the AV conducting bundles and a continuous conduction sling that can be present. Finally, for straddling mitral valves, we see highly variable presentations in terms of continuous conduction slings, as well as either an anterior or posterior AV node, and it's it's not really clear in any given patient which one will be present. The next major category in terms of twin AV nodes is the heterotaxy syndromes, and specifically right atrial isomerism. This early report by Bob Anderson and his group out of the UK histologically described twin AV nodes and a conducting sling in a patient with right atrial isomerism. And this was a very sort of important landmark study. Follow-up studies have shown even greater detail in terms of the conduction system anatomy. In particular, we find that the bundle branches have a unique course. The right bundle branch typically arises from the anterior bundle, and the left bundle branch typically arises from the posterior bundle, or sometimes from both the posterior and anterior bundle, which is important when we're talking about EP studies for these patients. Further study of heterotaxy syndrome has shown quite clearly that both left atrial isomerism and right atrial isomerism can be associated with twin AV nodes connecting AV bundles and conduction slings. Left atrial isomerism in particular when there is left-handed topology of the right ventricle, in other words, L looping, or in cases with single right ventricles. Likewise, for right atrial isomerism, we find a similar phenomenon where left-handed topology is associated with twin AV nodes connecting AV bundle and conduction slings, similar to the single ventricle situation as well. But overall, we do find that left atrial isomerism is less associated with connecting slings. Now, this study from Japan in 1983, I think, is very interesting. This is one of the few studies, in fact, the only study that shows twin AV nodes with connecting AV bundles that insert separately into the ventricular myocardium. Almost all other studies have shown or described a continuous conduction sling in terms of the ventricular connections. And so I think this study is important as it shows a different phenomenon whereby there are separate connections into the muscle. Perhaps the most comprehensive study to date is this one by Bob Anderson's group out of the UK. They had 35 patients in total, 25 with left atrial isomerism, 10 with right atrial isomerism. And they found that overall left atrial isomerism was associated with twin AV nodes that both connect to the AV conducting bundles with a continuous conduction sling, and only 16% of patients overall. On the other hand, right atrial isomerism was always associated with twin AV nodes, and that in 50% of these patients, an intact conduction sling was found that could potentially support SVT. And when we look in more detail, we find that those with biventricular connections and left-handed topology are really the ones that are most likely to have connecting slings, continuous conduction systems with conducting slings, as well as 50% of patients with single ventricle type anatomies. For right atrial isomerism, we find that left-handed topology is again associated with connecting slings, and 50% again of the single ventricle patients. So I think the take-home point from the heterotaxy syndromes is that left atrial isomerism, really we know that all hearts contain at least a posterior node. They don't always connect to an AV conducting bundle. But when there is left-handed topology, an anterior node is also seen, and in many of these, overall 25%, connecting bundles and continuous conduction sling is seen. For right atrial isomerism, on the other hand, all patients have paired AV nodes or twin AV nodes, but of those, and they actually have continuous conduction slings as well. But in left-handed topology, those patients have connecting nodes that connect to the AV bundle, whereas in the right-handed topology, interruption in one of the other nodes is oftentimes present. What about the natural history of SVT in these patients? There are a series of studies, particularly for heterotaxy syndrome, and in particular right atrial isomerism. There's a series of studies out of Taiwan and China that have shown us that a very high percentage of patients with right atrial isomerism will develop SVT. The two studies out of Taiwan from 1998 and 2008, we see that almost exactly half of patients will develop SVT by the age of 10 years. And the predictors for this seem to be balanced ventricles in the second study from 2008. Overall, there is a case report where one patient developed ventricular fibrillation during an episode, but overall there's no effect on mortality in patients with SVT. The most recent study by Wu et al. From Taiwan looked at all of the heterotaxy patients in their follow-up period, which is over 20 years. And they found that twin AV nodes electrocardiographically were identified in 50% of patients with right atrial isomerism, 9% of patients with left atrial isomerism, and 40% of patients with indeterminate isomerism, similar to the pathologic descriptions. And they found that, again, SVT was most common in patients with right atrial isomerism, but also in patients with indeterminate isomerism, which I think is important. They found that risk factors, multivariate risk factors for SVT included indeterminate isomerism, and also the electrocardiographic finding of twin AV nodes. And this is essentially based on sequential EKGs. And finally, they found that atrial flutter does occur in these patients at an older age, typically in adulthood, with increasing frequency. What about the EP characteristics of twin AV nodes? So again, going back to the original description in 1995 out of Taiwan, there were two cases with twin AV nodes that had conduction over two separate antegrade AV nodes. The first case, however, did not have retrograde conduction. There's no SVT. The second case had retrograde conduction over the anterior node and had inducible SVT related to this. And this patient went on to have a successful surgical ablation performed. Since then, we have a number of studies that have described the electrophysiologic principles of SVT related to twin AV nodes. In particular, this one from the Boston group in 2001 really provided strict criteria for making the diagnosis of SVT related to twin AV nodes. They proposed the following 7 criteria. Number 1, you have 2 discrete non-pre-excited QRS morphologies that depend on the atrial rhythm. 2, anatomically distinct His bundle electrograms associated with each QRS pattern. Number 3, antegrade decremental conduction over both AV conduction pathways with a stable HV interval. 4 is a shift to the alternate pathway when the refractory period of the first is reached. I'm going to talk about how this is not always seen, however. Number 5, you have decremental retrograde AV conduction over at least one pathway. 6, complete antegrade and retrograde block with adenosine. And 7, inducible AVRT with antegrade conduction over one and retrograde conduction over the other. And we'll see that these are not always seen, though, in all cases. There's also been the following criteria proposed for electrophysiologic evidence of a continuous conduction sling, and I'll talk about all of these 5 criteria. They're all in the form of separate case reports. The first is lengthening of the HV interval with ablation of the contralateral AV node. So in this case, we have a patient with an HV interval of 57 milliseconds at the posterior node pre-ablation. After the authors ablate the anterior node, the HV interval at the posterior node lengthens to 90 milliseconds. And it's proposed that this suggests there's a continuous conduction sling. The reason we say this is that the only way to get a lengthening of the HV interval really is if you have a continuous conduction sling where you have conduction from the anterior node to the posterior node and the ventricle in parallel. So we're activating the ventricle and the retrograde His bundle at the same time, resulting in a short HV interval. When we ablate the anterior AV node, we then have conduction passing through that posterior node in series from the His to the ventricle, and the HV interval therefore prolongs. And so this suggests that there is a continuous conduction sling present. Another criteria is a positive but short HV interval at the retrograde node during tachycardia. In this case, the anterior node is serving as the retrograde limb, and we have a positive HV interval of 13 milliseconds. The only way to get a positive HV interval at the retrograde node is if, again, we have parallel conduction to the ventricle and the retrograde His bundle over a conduction sling. So there's rapid conduction through the conduction sling to the retrograde His bundle while we're also activating to the ventricle simultaneously. Another criteria that's been proposed, and this is, I think, a very interesting one, is prolongation of the AV interval with ipsilateral bundle branch block. Essentially what's happening here is that with bundle branch block, in this case the right bundle, and the anterior, coming off the anterior bundle, results in a longer circuit length to reach the ventricle. And this occurs when there are a continuous conduction sling, whereby the electrical impulse has to travel through the conduction sling to the other bundle be reached before it reaches the ventricular insertion, resulting in a long AV interval, which then normalizes when the right bundle branch recovers. If there are 2 separate ventricular insertions, then the activation of the ventricle would occur with similar timing regardless of bundle branch block. And then finally, I think one of the more recent ones is resetting of tachycardia associated with late coupled PVCs. In this case, the authors showed that with a late coupled PVC, there was no reset of the tachycardia, and then with an earlier PVC by 10 milliseconds, the tachycardia was reset. Importantly, they showed, though, that these PVCs had the exact same QRS morphology, suggesting that this was a concealed extra stimulus. And the authors essentially proposed that their extra stimulus was occurring in or near the conduction system itself, and that by the absence of progressive fusion or changes in the QRS complex, which would suggest additional antidromic penetration into the ventricular myocardium, if they're pacing in a continuous conduction sling, this would not occur, whereas if there are 2 separate insertions, one would see progressive antidromic penetration to the muscle. And so this is another criteria that's been proposed for patients with for continuous conduction slings. And finally, we have shown at our own center that you can simply map the conduction system to show this phenomenon. And this is ultra high definition mapping here. You can see these little rings are the His-Purkinje activation occurring over the anterior and posterior node simultaneously and reaching the crux, sort of not the crux, but the apex of the ventricular septum here. And then they're activating through the bundle branches, the ventricular myocardium, both anteriorly through the right bundle and posteriorly through the left bundle here. So one can simply show this with very high definition mapping, which we'll talk a little bit about later as well when we're talking about preoperative mapping. What about catheter ablation outcomes? certainly this is something we would like to improve. We have a recent multicenter study with a total of 59 patients that have helped inform some of this for future procedures. Importantly here, we had right atrial isomerism for most cases, 39, 8 left atrial isomerism cases, 8 indeterminate isomerism cases, and 4 other types of congenital heart disease, mostly CCTGA. And you can see the associated congenital heart lesions here. This figure shows us that the AV nodes tend to be located sort of midline in most cases. However, there's deviation to either side depending on the balance of the ventricles. And the important associations were pulmonary artery obstruction, common AV canal, bilateral superior vena cava, anomalous pulmonary veins, and importantly left-sided IVC in 50% of cases. We did find a highly variable number of criteria that were satisfied in these various cases. Not all criteria, the classic criteria, were satisfied, and I'll talk about that a little bit more. And importantly, in tachycardia, we found that the retrograde limb was the anterior AV node in most cases, as has been previously proposed, 50%. But the posterior AV node actually served as a retrograde limb in 30% of cases. And we had bidirectional SVT, so that either the posterior or anterior AV node could serve as a retrograde limb in a significant minority of patients, about 20%, suggesting you could ablate either node in those cases. I think one of the most important findings of this study was that the patients with vascular anomalies, whether in interrupted IVC, as seen in left atrial isomerism, or with Fontan versions of the Fontan, especially the extracardiac Fontan, those were the patients who tended to do the worst. They had failed ablation or recurrence in a significant number as compared to the patients without vascular anomalies. And this suggests that we should probably be taking these patients to the lab before they have their Fontan operation. This is a case example that's going to highlight some of these findings. It's an adult patient with right atrial isomerism and a prior extracardiac Fontan who had suspected SVT related to twin AV nodes. We took him to the lab. This is showing us the injection into the extracardiac Fontan. Here we're puncturing across the low portion at the IVC level into the pulmonary venous atrium using ICE guidance, which is our own approach. In sinus rhythm, you see here we have a right bundle branch block with inferior axis. But when we pace the ventricle, we have VA block. We don't have any decremental VA conduction, so we're not satisfying one of the initial criteria here. When we try extra stimuli, we get decremental conduction through the anterior AV node, but we cannot elicit conduction over the posterior node. Even when pacing near the posterior node, we don't see any conduction over that node. So again, difficulty establishing some of the classic criteria here. When we then do incremental atrial pacing, we induce an atrial flutter rather than twin AV node tachycardia. And so we go ahead and map this, and we see a localized reentrance circuit down at the inferior aspect of the pulmonary venous atrium. However, with isopaternal infusion, we do see a second tachycardia. This tachycardia is 1-to-1, and it's again right bundle now with a right superior axis, so highly suggestive of SVT related to twin AV nodes. When we entrain from the ventricle, we see a VAV response, which is also consistent with this. And when we map in more detail at the anterior AV valve annulus, we do find a His bundle potential, as seen here in the Penray 5-6 catheter. And during tachycardia, we are able to find an antegrade His at the posterior AV valve annulus, but again, not in sinus rhythm. We map ventricular pacing and tachycardia. We see a similar atrial activation, again suggests the diagnosis. And then when we put catheter pressure at the posterior node, we do see a His bundle potential emerge during this junctional rhythm from the posterior node, which I think is really the only way we could find a His bundle potential outside of SVT at the posterior node. So we decided in this case to ablate because of the concomitant atrial flutter that is right next to the posterior AV node, as well as documentation that the anterior AV node conducts very, very well. We decided to ablate the posterior AV node, and we see here now sinus rhythm over the anterior node, switching to accelerated junctional over the posterior node. And when this goes away and we ablate the localized flutter, we eliminate all of the tachycardias in this patient. And so this really highlights the situation where we have incomplete criteria for twin AV node tachycardia. We have difficulty accessing the anatomical substrate, and we have a concomitant arrhythmia to deal with, which I think are some of the considerations for these more older patients with SVT related to twin AV nodes. Now, one of the ways to get around some of these obstacles is to use stereotaxis. I'm not going to spend a lot of time on this, but this has been proposed, and it does have some benefits in terms of catheter stability. However, when you're talking about concomitant arrhythmia substrates, there is some limitation, I think, to the point-by-point mapping. Future directions in this population, we need to improve our catheter ablation outcomes. We should be considering preoperative studies in all patients that are going Fontan with high-risk lesions such as CCTGA and good septal alignment, as well as patients with heterotaxy syndrome. We also need, I think, to think about understanding the anatomy better, especially when it comes to helping our surgeons during complex biventricular repairs. We need to understand the anatomical electrophysiological correlations better, and we also could be considering preoperative or intraoperative mapping to guide surgical decision making. I'm not the first to suggest this. This has been suggested as far back as the 1970s by many authors, and we can do this preoperatively. However, I think for the younger patients, intraoperative mapping is probably the way to go, and this has been proposed and is being done currently at other centers. So with that, I'd like to thank you for your attention. If you have any questions at all, please feel free to reach out. This is my email. Happy to touch base. Thank you. Bye.